Cranial nerve examination. Cranial nerve 2. The optic nerve. To test this nerve, you are advised to test the following parameters. 1. Visual acuity. 2. Visual fields. 3. Optic fundus. And 4. Pupils. To test visual acuity. If there is a severe deficit. Note, if a patient can see light, movement, or can count the fingers. If there is a mild deficit, it is advised to record reading acuity with a wall or hand chart. Note, refractive error, which is inadequate focusing on the retina, for example, hypermetropia or myopia, can be overcome by testing reading acuity through a pinhole. This concentrates a thin beam of vision on the macula. To test the visual fields, gross testing can be performed by a confrontation test. For this, compare the patient's fields of vision by advancing a moving finger or, more accurately, a red 5mm pin from the extreme periphery towards the fixation point. This maps out the cone of vision. A 2mm pin will define central field defects, which may only manifest as a loss of color perception. In the temporal portion of the visual field, the physiological blind spot may be detected. A 2mm object should disappear here. During the whole procedure, the patient must fix their eyes on the examiner's pupil. Peripheral visual fields are more sensitive to a moving target and are tested with a Goldman perimeter. The patient fixes on a central point. A point of light is moved centrally from the extreme periphery. The position at which the patient observes the target is marked on a chart. Repeated testing from multiple directions provides an accurate record of visual fields. Central fields are charted with either a Goldman perimeter using a small light source of lesser intensity or a tangent screen. The Humphrey field analyzer provides an alternative and particularly sensitive method of testing central fields. Examination of the optic fundus can be done at the bedside or an OPD with the help of an ophthalmoscopy. For this, patient needs to fix his vision on a remote entity away from any glowing light. The examiner should use his right eye to examine the right eye of the patient and the left eye to examine the left eye of the patient. If the patient is wearing the glasses for the refractory error, then it is necessary to adjust the power of the ophthalmoscope. The examiner is supposed to approach the patient's pupil at a 15-degree angle on the plane of vision. Then a little maneuver of the ophthalmoscope lens will visualize the retinal vessels, which are traced back to visualize the optic disc. Findings like the clearness of the disc edge, hemorrhages, or white patches of exudate, focal ischemia, should be noted. Also, the width of blood vessels and arteriovenous nipping at crossover points can also be looked for. To visualize the macula, the patient needs to look at the light of the ophthalmoscope. For small pupils, the quick-acting mydriatic drop can be used to dilate the pupil, but this is contraindicated if either an acute expanding lesion or glaucoma is suspected. Examination of pupils. Findings like size, shape, equality, and reaction to light should be noted. In normal conditions, both pupils constrict when light is shown in one eye. This is due to the cross-connection of the oculomotor nerve. Similarly, pupil constriction occurs when the patient fixes the vision on a near object. In the case of the optic nerve injury, the direct reflex of the affected eye is lost, however, the consensual reflex is still present. Similarly, in the case of the third cranial nerve injury, both the direct and the consensual reflexes are lost in the affected eye. Few other pupillary abnormalities besides the second and third cranial nerve injuries are seen in a Dye's pupil, also called the tonic pupil. This is a benign condition usually affecting one eye in around 80% of cases. Clinically, there is dilated pupil and the patient complains of haziness in the affected eye. The pupillary light reflex is often absent to both direct and consensual light, and a very slow pupillary constriction could be seen even with accommodation. Another pupillary abnormality is seen in Horner's syndrome, where the pupil is smaller than the other side and is also associated with the ptosis and anhidrosis of the affected side. In the Argyll-Robertson pupil, the pupils are small and irregular in shape and do not react to light, but they do react to accommodation. These conditions are usually due to syphilitic infection, but they may also result from any midbrain lesion. The Marcus Gunn pupil is commonly seen in optic nerve damage, but is also abnormal in retinal or macular disease. It is characterized by paradoxical dilatation of the pupil with a swing light test.